All right, let's get started.
The only thing that I'll add is you will get a survey when you close out of the Zoom link at the end of the day. So if you have to go in and out or if you can't stay for the whole day, as Ben suggested, the feedback's going to be extremely valuable to build this and make it more beneficial for everybody moving forward. So we tried not to make the survey too long. So if you could just take a look at that when you have to leave for the day, we'd really appreciate it.
Awesome. All right. Well, let's go ahead and get this started. Really excited to talk to everyone and have the inaugural presentation here with our conference. So I'm Landon Mueller. I'm on faculty at Georgetown University and with MedStar Health. I split my time between emergency medicine and sports medicine. And I have a particular kind of teaching passion for shoulder reductions. And that's what we're going to talk today about pain control for anterior shoulder reductions and changing the paradigm of sedation. So I want to change this paradigm that when a patient walks into the emergency department with a shoulder dislocation, that we automatically get out the propofol. I don't know what all of your experience has been like, but I swear at every emergency department I've worked at, as soon as we get the x-ray and diagnose the patient with a shoulder dislocation, the nurses are like automatically going and putting in an IV, they're calling respiratory therapy, they're asking like what dose of propofol you want, and we don't need to do that. And especially with those of us in EM sports medicine, we know that you don't have to reduce shoulders with propofol. Like athletes can do it on the sideline, athletes can do it in the game, like this example. I think this is a pretty fantastic example. This is another example of an athlete self-reducing their shoulder during the middle of a game. And so obviously there's something about this of why we're able to, like why these athletes are able to self-reduce their shoulder. Probably for these two athletes, they may have done it before, so they have a little bit of experience. But there's got to be something different as to why we can do that without sedation as opposed to requiring propofol. Certainly, one aspect of that is time. We know that when there's a delay to obtaining a reduction, that there's actually decreased success. So basically, this one study found that for every 10-minute delay, and this was in the emergency department, every 10-minute delay in achieving attempt at a shoulder reduction, it decreased your reduction success by 7%. So we know that one thing is getting to the shoulder quickly. But I don't think that tells the whole story. And I think a lot of it has to do with culture, and specifically our culture as emergency physicians in the United States and maybe even Canada. I would hazard, I've looked at some studies that have shown that shoulder reductions are actually the single most indication for procedural sedation in the emergency department. And that is not the case in every country. One survey in the Netherlands found that actually an intra-articular block was the most used form of pain control for shoulder reductions. About 26% of shoulder reductions were done with intra-articular block, and only 11% of them needed sedations. So I do think that this is a cultural thing as well with emergency physicians in our part of the world where patients come in with shoulder dislocations, and we go ahead and automatically reach for the propofol. So I want to talk about some of the ways that we can reduce the shoulder without using propofol. We're going to talk a little bit about the biophysics of it, about why we have so much pain with shoulder dislocations, and then we're going to go over three methods that we can use to achieve that. So let's talk about why shoulder dislocations hurt so much. And let's review a little bit of anatomy, especially as EM sports docs. We actually need to know this anatomy, whereas a lot of our just straight EM colleagues don't necessarily know this. So when we look at the anatomy of the shoulder, we have our glenohumeral joint, starting with our glenoid and our humeral head. On top of that, we have a layer of soft tissue structures that we worry about when they are damaged with an anterior shoulder dislocation. So you start with your labrum, and then on top of that, you have your synovial capsule layer. On top of that, you have a series of glenohumeral ligaments. And then you have your rotator cuff muscles, including your subscapularis, your supraspinatus, infraspinatus, teres minor. The next layer on top of that, you have your long head of the biceps. The short head of the biceps isn't really involved in dislocations. And then, of course, you have your deltoid. So you have this kind of onion type layer of structures that are all affected in shoulder dislocations. And if we take a slice through all those layers and we look kind of through that anatomy, kind of from a top down view, this is a little diagram that I have made to represent all of that. So we have our deltoid, we have our biceps tendon, our humeral head, and our glenoid. And remember all the soft tissue structures that are occurring in this area. When you have an anterior dislocation, what happens is that humeral head is shifted forward. And what that does is that puts a lot of strain and especially stretch on the rotator cuff muscles, especially the supraspinatus, infraspinatus, and teres minor. And when we know that muscles are stretched, that inherently causes spasm and that triggers pain. In addition to that, once you've torn through all those soft tissue structures, what ends up happening is it backfills with hematoma. Whenever we have trauma to tissue, we get bleeding, essentially bruising behind, and so it backfills with hematoma, and then that pressure in the synovial capsule can also cause pain. And all of this, essentially like stretching of the rotator cuff muscles, that hematoma, that humeral head, all of that essentially creates this downward and inward force that basically shunts that humeral head onto the glenoid. And that's one way that I like to think of how we get our Hill-Sachs lesions or deformities on the humeral head from a shoulder dislocation. And so this is what we have to contend with when we're trying to reduce a shoulder. And it's a good, I think, concept as well for any of our reductions in the MSK world, is that you essentially have to overcome any forces of muscular tension, muscular stretching, as well as trauma and hematoma. So we have this giant force. And the biggest way that we can help reduce the joint is actually to decrease that amount of force. When you decrease that amount of force, everything kind of relaxes and allows the humeral head to basically slide back into the glenoid. So that is especially how we can achieve reduction with some of these non-sedation techniques, is by focusing on relaxation. And let's start with our first set of pain control that we can utilize, which is actually no pain control or biomechanical techniques. And I think this is a little bit, heresy in the emergency medicine world in the US, but again, in the rest of the world and on the sidelines, we know we don't have to use sedation or any pain control at all. And there have been numerous studies showing various sedation-free techniques. And I'm not going to list all of them, but all of these pictures are various techniques that have been described in the literature on how to reduce a shoulder without any form of pain control or sedation. And so it's like a ton of different techniques that all of them primarily focus on a few aspects, the biggest one being relaxation. Now, I'm going to pull some data from this one trial out of the Netherlands because I think it's the most recent and best data that we have for non-sedation techniques. And they basically looked at three different techniques, including Cunningham, Milch, and scapular manipulation. And in general, when employing these three techniques, they found that you can achieve reduction success without sedation about 2/3 of the time. And I think this mirrors my own personal practice, which is I find that somewhere around 2/3 of patients I can actually coach through and get their shoulder reduced in the emergency department without needing any form of pain control or sedation. Now, again, this is all going back to, I have a whole separate lecture on how you actually achieve relaxation and the techniques you can use. But I like this quote from a different study, basically talking about how you can achieve reduction without sedation. And it's a particular focus on the gentleness of your actions while performing any technique. And whenever pain or spasm is felt, stopping the action to allow the muscles to relax. So again, just kind of highlights that this is possible. And it also highlights that this is not exactly painful. That study out of the Netherlands found that just because you're doing a reduction without pain doesn't mean that it actually increases the pain. So in that study, they found that the average pain scale out of 10 was about 7 on arrival. And they noted that the pain that they felt during the reduction was actually different. It was actually decreased from that. And I think that has to
Yeah,
do
we
with
do.
coaching the patient to
The meat
relax when
bags.
it is actually not a super discomforting thing. So
I'm
I
just
want you
gonna
to consider
screenshot you
that
this text.
in terms of the hundreds of different techniques, finding one that works for you,
No,
I think is the key. Moving on to our next
I'm on
form of
Zoom
pain
for this
control,
conference that
we
I'm
have
speaking in right
intra-articular injections. So this is where you take a needle and you inject lidocaine, bupivacaine, whichever form of anesthetic you choose. I typically use lidocaine, but you inject that into that synovial capsule, basically in that hematoma space, and that lidocaine provides anesthesia to the glenohumeral joint. Now, I typically do this under ultrasound. You can do this landmark based, and there are studies in the emergency department looking at landmark and ultrasound guided. But I think as EM sports medicine docs, especially, we have the skill. I think we have the toolkit to perform this with ultrasound. So this is an example of a needle going into the hematoma space during a glenohumeral dislocation and um, inject it into that area. We're going to talk about the evidence behind this in just a minute. So that is our intra-articular injection. And then our last form of non-sedation techniques are our peripheral nerve blocks. And we have a couple of options with this. But taking a step back with the anatomy of the nerves to the shoulder, this is the diagram basically looking at the entire brachial plexus and most of its branches. But the shoulder, everything that innervates the shoulder, we can narrow down to just a couple of cervical nerve roots, specifically C5, C6, and C7. These three nerve roots basically provide the entire sensory and motor control to the glenohumeral joint. And that is through branches of the suprascapular nerve, the axillary nerve, the lateral pectoral nerve, and the inferior subscapular nerve. Now, you don't need to remember the specific nerves. The subscapular one is a little bit more important because that tends to provide the most innervation. But in general, what you know is that if we block those nerves higher up, then we can achieve pain control at the shoulder. And that's exactly what the interscalene injection does and the supraclavicular injection. So the interscalene injection is a little bit higher up in the neck. It's basically just after those nerve roots come together to start forming the trunks of the brachial plexus and occurs between the anterior and middle scalene muscles, hence the name interscalene injection. Now, the important thing about the interscalene injection is that it for sure blocks the suprascapular nerve because the suprascapular nerve comes off pretty high, basically right around the level of the interscalene muscles. And so the interscalene injection is thought to be kind of the gold standard for achieving total sensory blockade to the entire shoulder. But there are studies showing that the supraclavicular injection can also provide adequate pain relief. Again, you're probably not getting the suprascapular nerve because that has broken off before you get to the supraclavicular site, but you're getting the rest of the nerves going to the shoulder, including that axillary nerve. So that is an option. And then there have also been case reports and a couple studies looking at just the suprascapular injection. So this occurs basically on the posterior aspect of the shoulder. After that suprascapular nerve has branched off and travels posteriorly, it then basically travels through the spinoglenoid notch of the glenoid, and that is where we like to block that suprascapular nerve. And this is probably achieving about 70% of total blockade to the shoulder, which is a pretty decent amount and can facilitate reduction. So those are our three peripheral nerve blocks that we can utilize to perform reduction. And I'm not going to focus on the specific techniques. There are lots of other resources for that. But I do want to highlight this one study that was published in 2022 that was basically a comparison of all these different techniques. It specifically compared 6 different intra-articular injection studies versus 4 peripheral nerve block studies. I believe 3 of those were interscalene and 1 of those was a suprascapular nerve block study. And they compared that all versus sedation. And so when we look at the difference between all of these, there was no statistical difference in reduction success between the 3 methods. Now, when you actually look at the plots of the graphs, you can see that maybe there was a slight trend towards favoring sedation when you look at intra-articular blocks. Maybe there was a slight trend towards favoring peripheral nerve blocks. It's hard to say, but ultimately there was no statistical difference. So essentially, our efficacy in terms of getting reduction is about the same. When we look at some other key, I think, key metrics, specifically patient satisfaction, you see that there was no statistical difference between the 3. However, there was probably a trend towards favoring sedation over intra-articular block and over peripheral nerve block. And to be honest, that doesn't surprise me, right? Like giving someone a big slug of propofol is probably going to make them come out of it feeling a little bit better about their experience than having to kind of work with an intra-articular block or a peripheral nerve block and get the needle injected into them. So it doesn't surprise me, but it's also not so much in favor of sedation, that patients hate these blocks. When we look at length of stay, this is where a lot of the data actually shows that these non-sedation techniques are really helpful. And this has been my experience as well. Intra-articular blocks, the data is pretty conclusive that it is much faster to get these patients in and out of the emergency department than to do sedation. And we can all know that, intuitively that when we have to do a sedation in the emergency department, we're having to round up nurses, techs, get an IV, get all the equipment ready. So it's definitely going to prolong compared to just doing this nerve block. Or sorry, compared to doing an intra-articular block. In terms of the peripheral nerve blocks, the studies are a little bit more mixed. They trend towards favoring shorter stays with the peripheral nerve block, but it doesn't quite meet statistical difference in this study. And then finally, when we look at adverse events, which is a huge reason to do these non-sedation techniques, basically the study found that intra-articular blocks and peripheral nerve blocks are safer than sedation in terms of having fewer respiratory adverse events. And when you look at even smaller adverse events, in general, the intra-articular block and peripheral nerve blocks have fewer events than sedation. Sedation has been shown to have more hypotensive events and things like that. So I think this is pretty decent evidence that, these blocks are essentially equivocal. They're at least not significantly worse than sedation, and in many facets, they're better. So, what do I personally do with my algorithm? How do I employ all of this? This is kind of my framework. I go and assess the patient, and the first thing I ask myself is this patient distraught? Because if they are, if you cannot calm them down, if you cannot get them in a good position to work with you, it's just not going to happen. And so for those patients that are just distraught, I just go to sedation, and that's just what you have to do. But that's, very rare. I would say maybe 2 times out of 10 that you just cannot work with a patient. If a patient's willing to work with me, I'll try to get them into the proper positioning. And this means if their arm is held in abduction, held away from the arm, I try to see if I can just gently adduct their arm, because that's a good way to, one, see if they're coachable, see if they're able to work with you, and see if they're able to tolerate just small, gentle movements of that arm. I also will get them up out of the stretcher. And this is, especially applies to like our typical shoulder dislocation in our 20, 30-year-old male. Like get them up out of the stretcher, get them sitting upright in a chair, because that puts their scapula in a better position, puts everything into a better position. And then I start working with them. If I can do all that, I usually have pretty good success with my like no pain control techniques. And I've, gotten these patients in and out of the emergency department in under an hour. Basically, they come in, get their x-ray, I reduce it, get their reduction films, and then they're out within an hour. So that's like my favorite patient is the ones that are willing to work with you and get in that positioning. If I start kind of manipulating them, they're willing to work with me, but they seem to be like they're in a lot of pain and they're not able to get that perfect positioning, then I'll kind of assess some other risk factors. These risk factors listed over here were found in another study to be risk factors for difficulty with reduction success. So basically, older patients, those who have had recurrent dislocations, those who have associated fractures with the dislocation, and then of course prolonged dislocation. Those are all risk factors that they might need sedation and have a harder time going back in. And that's been my experience as well. Again, the 20, 30-year-old male, first time dislocation, those you can usually manipulate with kind of gentle techniques and no sedation, no pain control. Whereas like I've had a couple, 70-year-old grandmas who fell and instead of having a glenohumeral fracture, they have a dislocation. And those have been a little bit harder for me to do without sedation. With that said, if they have those risk factors, I'm still going to attempt an intra-articular block. That's a little bit more of my personal practice because I feel very facile with that procedure and I think I can get it done pretty quickly. And I'll try that and see if that provides enough pain relief. If, however, they do have those risk factors, what I'm also going to do concurrently is I'm going to do that intra-articular block and I'm going to have my nurses set up for sedation just in case we don't get it. So at that point, I'll have them start getting an IV, maybe start drawing up the propofol just in case I can't reduce it with the intra-articular block. If they don't have any of those risk factors, let's say it is that, so that's just summarizing that I would start getting ready for the propofol. If they do not have any of those risk factors for kind of a hard reduction success, then I'm going to still move to an intra-articular block. So that's basically my second line treatment for any patient. But if I fail with that, if I still can't get it reduced, they're still in a lot of pain, I kind of assess again, are they still cooperating with me? Do I get the sense that they really want the shoulder back in? They're willing to work with me with these non-sedation techniques. It's just that they're in a lot of pain or having trouble reducing it. If they're cooperative, then at that point, I will try a peripheral nerve block, either an interscaling block or a suprascapular nerve block. And if I fail then we have to go to sedation. If I feel like after the intra-articular block, they're getting tired, they're getting mad that the shoulder's not back in, then of course I'll have to go to sedation. So that's kind of my general algorithm. Again, I find with a lot of our typical patients, the first time dislocators, your 20 or 30-year-old males, you can really coach them. And it takes some experience and some time, but you can coach them and you can get them through without any form of pain control. Those after that sometimes need intra-articular blocks as my second line. Um, the kind of third line for the appropriate patient is the peripheral nerve block. And of course, if all that fails, then we still have sedation. So hopefully, again, I know I didn't go into any detail on the specific blocks and how to perform them, or even the specific techniques for non-pain control techniques. But I hope that this kind of opens your mind to all of the available sources that we have. And I hope it triggers you to maybe kind of read into something a little bit more and practice with some of these techniques. Thank you. Any questions?
Great. Thanks, Landon. That was super helpful. I think, all of us have our own approaches to these patients and to see yours, with your experience is I think is really beneficial. It looks like one of the questions that was posed in the chat was obviously
Yeah.
anterior dislocations are much more common in the emergency department. For that rare posterior dislocation, does your algorithm change at all?
Yeah, yeah, I see the question in the chat. Yeah, for a posterior dislocation, basically this algorithm doesn't apply. Basically, if it's a posterior dislocation, I'm just going to sedate. That one's rare enough, and the anatomy and the reduction techniques are definitely, I think, less familiar with myself and with all of us since we see them pretty rarely compared to anterior dislocations. So for those, I would just do sedation.
All right. And
Looks
then it
like
looks like, yeah, you can see the chat. So you see
yeah,
the next
I've got it
question
pulled up.
that
Yeah.
came up?
So
Yeah.
Matthew Straight asked if I'm a fan of aspirating the hematoma. I generally don't. I think it's totally reasonable to do it. I haven't seen any literature in terms of, comparing aspirating the hematoma versus not. I think it does make some intuitive sense. Again, we know part of the reason why there's a lot of pain with shoulder dislocations is again that hematoma is forming, and the hematoma in that synovial capsule is basically stretching and distending that capsule. And whenever we have distension of a structure, that often triggers pain. So the idea is that you aspirate the hematoma and then you inject your anesthetic after that. I think the biggest reason why I don't do it is honestly just a resource thing. I if I was going to aspirate and then inject, I would need an assistant to help kind of clamp my needle down while I take off the syringe that I'm aspirating the hematoma on, and then put on a syringe containing my lidocaine to inject. You could do that. I mean, most of our departments we have techs, nurses that would be helpful. I tend to just do these on my own. I tend to just gather the supplies, the ultrasound, go in the room, and just do it very quickly. Um, and so that's why I tend to just use the anesthetic. But if you want to aspirate the hematoma, again, I think it makes physiological sense.
And do you
And then
always use
Marissa
ultrasound for
asked,
intra? Yeah, do you always use
yeah,
ultrasound
yeah,
for
yeah.
intra-articular block?
Definitely ultrasound. There are studies, again, looking at the two, and there are studies showing that landmark-based does work. Now, there was also one really interesting study that basically they had ED providers do a landmark-based injection, and then they used an ultrasound to basically see at the same time if that injection with landmark guidance was actually going in the joint. And I'm pretty sure it was something like 41% of the time it wasn't actually getting intra-articular. And so I would think, especially those of us EM sports, I think doing it ultrasound guided is the way to go. Um, Looks like Marissa asked, "Do you use ultrasound guided technique to perform?" Yes, yeah, that's what we just answered. And then Alex asked if I get X-rays on all of my shoulder dislocations. Um, I do, and that is primarily just for a documentation purpose. I think it's very reasonable. We have great studies showing that ER docs are capable of diagnosing shoulder dislocations with ultrasound. And I personally bring the ultrasound into the room to confirm reduction. So I am still getting X-rays before and after, and that is primarily just to document to my orthopedic colleagues who may not know, that this ER doc has the skills to diagnose dislocations just with ultrasound. So I do get the X-rays to confirm, but what I like to do is bring the ultrasound in the room, and that way I confirm that the shoulder is back in with ultrasound. Because how many times well, let me rephrase this. With the gentle techniques, especially, because of the method that you're using, oftentimes the humerus slips back in and you don't feel that really satisfying clunk. And so you'll kind of be doing some like gentle techniques, whether it's like the Cunningham or a Milch technique, and you're just kind of going nice and slow, coaching the patient to relax, and the humerus just slides right in. And you don't really notice until like 30 seconds later, you look at the contour of the shoulder and everything kind of looks back to normal. And you're like, oh, did the shoulder go back in? That's why I like to have the ultrasound in the room, because then I can just put the ultrasound on and confirm that the humerus is back in. So that's what I like to use that for.
Great. Landon, we have a couple of questions in the Q&A. Just
Yeah.
to piggyback off of what you were just discussing, I know you mentioned Cunningham, you mentioned Milch. What's your preferred technique for the unsedated reduction? What's your first line?
So I have a whole separate lecture on how I do it. But in summary, I do a series of three techniques. So I initially try basically a Cunningham plus scapular manipulation. So I'll get the patient and I'll get them, sitting up with their arm. It's hard to show without anyone here, but get their arm on my shoulder. And then I start uh, basically massaging their deltoid, massaging their biceps tendon. That's like the traditional Cunningham technique, but I add a little different flair to it where I often focus on then reaching around and applying some scapular manipulation. Because what I find is if you're able to get their arm in that adducted position and a little bit flexed, and then you add in the scapular manipulation, that really is my like secret sauce for that technique. But if that doesn't work, then I will try basically a modified Milch, which is some external rotation and abduction away. And if I'm able to get them up to about 90 degrees and it still hasn't reduced, then I say, okay, external rotation hasn't worked. Let me try the opposite. So internal rotation. So then I'll bring him back to center, bring him forward flexed, and I'll try a technique that's called the Bokor-Billman technique, which is basically you bring them in adduction and then internally rotate. So basically, what my thought is you're trying to manipulate that humeral head in all of its different directions to try and get back in.
Awesome. Um, there's a two-part question between
Mhm.
Michael and Daniel in the Q&A as well. The first question is how much volume of lidocaine do you use in your intra-articular block? And then what do you like to use lidocaine? If so, which concentration, or do you typically go short-acting, long-acting, or a combination of both?
I just do 10 cc's of whatever we have in the Pyxis, which is usually 1% or 2%. If it's 2%, that's totally fine. I find that if you have a good ultrasound guided injection, like the examples that I gave, where you see the hematoma and you see the needle going into the hematoma, all you need is 10 cc's. There's some thought that you could, with a lot of different injections, you can add in saline to kind of spread and diffuse the anesthetic. But again, I don't want to distend that synovial capsule too much. So I just go 10 cc's of lidocaine. With these procedures, I don't use a long acting such as bupivacaine or ropivacaine, just because I'm just trying to get the shoulder back in. And we know that once the shoulder's back in, the pain level essentially evaporates.
All right, great. Morgan put a question in the chat. For the Swedish study you mentioned, did they train the physicians on injection techniques, or was it retrospective and therefore the study results would have been
Yeah.
more user dependent?
Yeah, for that study, Morgan, it was just retrospective. It was actually, I think, just a survey, so it's not the highest level evidence. It was basically a survey to the Netherlands ER docs, basically being like, in your shoulder reductions in the last year or so, what pain techniques have you used? So there might be a little bit bias where the Netherlands docs want to, make it look like they're using these non-sedation techniques more. I wouldn't, look at that as gold. To me, it just kind of provides evidence again that other cultures, other emergency physicians may be using sedation less than we are.
Great. Are there any contraindications to performing a nerve block or an intra-articular block from your perspective?
Yeah, certainly, when we're talking about intra-articular blocks, the only real contraindications are like infection overlying and patient refusal. There's very minimal risk with the intra-articular block, in my view. The peripheral nerve blocks have a little bit more nuance to them. Again, infection is one risk, especially with the interscaling block. It can lead to phrenic nerve paralysis on that side of the injection. Um, the phrenic nerve comes off around the brachial plexus, and so you could theoretically get some basically diaphragm paralysis on that side. Now, most of the time, if we're doing this in healthy 20, 30-year-olds, again, that's not a big deal, especially if you're using lidocaine that wears off in an hour. There's almost no studies or data showing that there's long-term effects from that. But theoretically, if you have an older patient or a patient with respiratory compromise, specifically asthma, COPD, then an interscaling block might not be the best choice for that. That risk is far less with the supraclavicular block and far less with the suprascapular block.
Okay, awesome. Well, I'm looking forward to 2026 Landon's talk about block techniques. The last
Yeah,
question that I
let's
have
do
for
it.
you, so we've got a variety of learners, residents, fellows, early
Mhm,
attendings, very many of which haven't had experience with blocks in the past, with nerve blocks. What
mhm.
resources would you direct them towards in order to be able to gain more comfort with this if they wanted to try it on the next shoulder dislocation that they had?
So I think Highland ultrasound is usually a great, like if you just Google Highland ultrasound, that's a program out of California. They have fantastic nerve block videos for pretty much all the peripheral nerve blocks. I think they also have intra-articular blocks as well. Um, I'll make a plug. We're hopefully at some point finalizing the internet book of musculoskeletal ultrasound that I'm working on with John Keel, who's speaking later today. Um, Hopefully we can get that published at some point, and a lot of like my videos that I have in the works will be on there. But for now I would stick with Highland ultrasound, and then if you are looking for more advanced techniques, NYSORA, so NY is a anesthesiology specific reference, but they have fantastic like anatomical diagrams and videos on how to perform these blocks as well.
All right, fantastic. Well, Landon, that was That was great. I mean, I think all
Mhm.
of us aspire to have the quality of slide that you had over the last 25 minutes. So,
Thanks.
thanks for taking your time to share your expertise, and yeah, hopefully we can follow this up next year.
Yeah, thanks everyone.